I'm Allison Evans. I'm on the board of ASPEN. I've been on the board maybe now for, I don't know, a year, maybe two. I don't know, it all runs together. And so I'm going to introduce our next speaker, Rachel Leong. And she received her doctorate of pharmacy from the University of Georgia, where she first became interested in nutrition after hearing Dr. Adina Hirsch give a lecture on both her career and parenteral and enteral nutrition experience. This led her to pursue a fellowship in nutrition support at Emory University Hospital, and she is currently in her second year of a nutrition support fellowship, and her current research project is on refeeding syndrome. So let's welcome Rachel.
Doing so far? Good. All right. Again, thank you, Allison, for that introduction. My name is Rachel, and I'm so excited to be here today. It's a really full circle moment for me because not too long ago, as a student, just like a lot of y'all. And I think it's appropriate that we talk about refeeding syndrome right before lunch. So Nutritious, it's suspicious. Oops. I just have to click down here. All right. I have nothing to disclose today. And our objectives for this presentation today are to describe the pathophysiology and clinical presentation of refeeding syndrome, to discuss the importance of screening patients at risk for refeeding, to summarize the literature regarding identification, prevention, and treatment of refeeding, as well as to apply our clinical knowledge on refeeding towards a patient case. First, I'd like to kind of start off with the history of refeeding syndrome, since it actually dates back to the 5th century BC, when Hippocrates first wrote that if a person goes 7 days without eating or drinking anything, in this period, most die. But there are others who survive, and others are persuaded not to starve themselves to death, but to eat and drink. However, the cavity no longer admits anything because the jejunum has grown together in that many days, and these people too die. Though Hippocrates misidentifies the cause of death, this passage likely represents an early description of refeeding syndrome. In 1939, when World War II prisoners of war were returning, after having experienced a prolonged period of starvation, they had noticed that it had precipitated cardiac failure, as well as unexpected morbidity and mortality. This prompted Dr. Ansel Keys in 1944 to conduct the Minnesota starvation experiment in order to gain insight into the physical and psychological effects of semi-starvation and the problem of refeeding civilians who had been starved during the war. The results from this study showed the intense decline caused by starvation and offered some guidelines on rehabilitation. In 2006, the National Institute for Health and Clinical Excellence, or NICE, put out guidelines on refeeding syndrome. And recently in 2020, the American Society of Parenteral and Enteral Nutrition, otherwise known as ASPEN, put out consensus recommendations for refeeding syndrome. So throughout this presentation, I'll be comparing both the NICE and ASPEN guidelines to better understand how our definition and management of refeeding has evolved over time. All right, so in the ASPEN 2020 consensus recommendations, they have a definition of refeeding syndrome. They establish assessment to categorize risk of refeeding. They provided detailed diagnostic criteria, as well as recommendations for prevention and treatment of refeeding in at-risk patients. So how ASPEN defines refeeding syndrome is as a measurable reduction in levels of one or any combination of phosphorus, potassium, and/or magnesium, or the manifestation of thiamine deficiency, which can develop shortly within hours to days after starting calorie provision in an individual who has been exposed to a substantial period of undernourishment. Refeeding can manifest in a wide variety of severities, from slight clinically insignificant decrements in electrolyte levels to severe and sudden decreases, which lead to or risk development of an organ failure if it's not preempted or corrected. So diving a little bit deeper into why this all occurs, so with the pathophysiology of refeeding, starting off with that starvation and malnutrition phase where the body is undergoing glycogenolysis, gluconeogenesis, and protein catabolism. So protein, fats, minerals, electrolytes, and vitamins are all being depleted, which and also leads to salt and water intolerance. Once feeding is started, the body switches to anabolism, so the introduction of fluids, salts, nutrients, with carbohydrates being a major energy source, so thinking about dextrose sources. This leads to increased insulin secretion. With the increased insulin secretion, it leads to increased glucose uptake, increased utilization of thiamine, as well as increased uptake of potassium, magnesium, and phosphorus. This leads to low levels of our electrolytes, low thiamine, and salt and water retention, which is what constitutes as refeeding syndrome. So displayed here are some of the signs and symptoms that can be seen with severe refeeding syndrome, kind of for your reference, just to see based on the different electrolytes as well as low thiamine, what kind of symptoms can be seen. Due to all these shifts in fluids and electrolytes, refeeding can manifest in a variety of different ways. Hence why we really call it a syndrome rather than a disease, since multiple anomalies and abnormalities are being involved, which lead to a varied clinical presentation. So in terms of the incidence of refeeding syndrome, overall there is an absence of a universally accepted definition, which is why the reported incidence is relatively low, only around 0.43 to 18% in hospitalized patients. And I'm sure for my hospital colleagues, we can attest that it's much higher than this. However, it's generally been accepted that hypophosphatemia is considered one of our hallmarks of refeeding syndrome. And there's also a prospective cohort study done in the ICU where patients who were starved for at least 48 hours, hypophosphatemia was reported in 34% of those patients for an average of around 2 days after feeding was restarted. So next I'll be discussing our malnutrition and refeeding risk assessment. I want to first start off by stating that malnutrition has really been a hallmark component to assessing refeeding. So prior to all of our guidelines and recommendations, this was largely what was used to evaluate risk for refeeding. However, you'll notice with the NICE and ASPEN guidelines, they both include assessment tools specific for assessing refeeding risk. So we'll learn that there are many more factors than just malnutrition to help assess for refeeding syndrome. So I'll start off with my first poll question. So for those on Zoom, it should pop up with some options. And then in person, if y'all could just raise your hand for the answer that you think it is. So how often do you utilize malnutrition and or refeeding syndrome screening tools in your daily practice? So for those who say A, daily. Okay, good, use them daily. B, a couple times a week. Okay. C, almost never. And D, maybe none of the above. All right, so it looks like on Zoom we got 62% saying daily. That's awesome. All righty. Just gonna. Oops. All right, so listed here are some of the malnutrition screening tools. Again, for your reference, there are so many, and I will go into detail a little bit later on some of them. Some used specifically for the ICU population, so depending kind of where you work and the different malnutrition screening tools may be of use to you. So my first study is on the risk factors of refeeding syndrome in malnourished older hospitalized patients. And it evaluates the application of both malnutrition and refeeding screening tools available in order to perform a complete risk assessment. So in this study, it showed that 75% of geriatric hospitalized patients with risk of malnutrition also showed significant risk of refeeding syndrome. Overall, the prevalence of malnutrition is high in hospitalized patients, which is why screening for risk is key. So the malnutrition screening tools used in this study were the Mini Nutritional Assessment Short Form, or MNA, the Nutrition Risk Screening Tool, or NRS, and Malnutrition Universal Screening Tool, or MUS. And so looking at all these tools, they look at really similar criteria in terms of reduction in food intake, recent weight loss, as well as BMI, with some differences including mobility, neuropsychological problems, age, and presence of acute disease. They utilized the NICE assessment in order to identify patients at high refeeding risk. So whether they had greater than one of the following or two of the criteria in order to meet that high refeeding risk. So again, looking at very similar criteria of BMI, recent weight loss, recent intake as well, with some differences including low levels before feeding. So specifically looking at potassium, phosphorus, and magnesium, as well as their history of alcohol misuse or recent drugs such as insulin, chemo, antacids, and diuretics. So looking at our study population, it was stratified by gender, with 65% being female. The average age was around 83. And overall, the females had a decreased height, weight, BMI, calf circumference, and recent weight loss. They maintained normal labs. And for our risk of refeeding syndrome overall, they had 70%. So looking a little more into our results, figure A shows the percentage of patients either at or not at risk of malnutrition. On our x-axis is the nutritional screening tools that were used, and on the y-axis are percentage of patients. So I'd like to direct your attention to the NRS screening tool that was used. It showed that around 75% of its patients were at risk of malnutrition. And on figure B, it shows our percentage of patients either at or not at risk of refeeding syndrome. So applying that percentage of patients at risk of malnutrition, they also showed a similar risk for refeeding syndrome in the NRS screening tool with around 75%. So in comparison to the other two tools that were used, they were not as accurate at predicting refeeding risk. And so most recently, our ASPEN consensus criteria also put out ways to identify adult patients at risk for refeeding syndrome. The difference being from NICE that they categorize them with either moderate or significant risk. Again, looking at very similar criteria, so a BMI of either 16 to 18.5 as moderate and less than 16 as significant. Again, recent weight loss, either 5% in the last month or 7.5% in 3 months or greater than 10% in 6 months. Recent caloric intake, so none or negligible intake for either 5 to 6 days or greater than 7 days. They also looked at any abnormal pre-feeding electrolytes, specifically potassium, phos, and magnesium. So if they were minimally low or normal versus moderately or significantly low, requiring either minimal or single dose supplementation or significant or multiple dose supplementation. The ASPEN criteria also included a physical exam portion to this, so loss of subcutaneous fat and muscle mass, as well as included a section for any high-risk comorbidities. And this is a bit of a limitation, as kind of it's up to the clinician's judgment and assessment whether it's moderate or severe disease. So I've included for your reference how ASPEN characterizes fat loss and muscle wasting, as I mentioned before, since it was in our refeeding risk criteria. And in terms of the populations with increased refeeding syndrome risk, I've kind of compared what the NICE and ASPEN considered as populations with increased risk. So similarities include patients with anorexia nervosa, chronic alcoholism, our oncology patients, post-op patients, as well as chronic malnutrition, with some differences in the NICE criteria, including our elderly patients, patients with morbid obesity, however, with profound weight loss, long-term users of antacids and diuretics. And in the ASPEN criteria, they include patients with dysphagia and esophageal dysmotility, failure to thrive, hyperemesis, as well as post-bariatric surgery. That brings us to our patient case. AG is a 73-year-old female who presents for scheduled surgery. She has a past medical history of colon cancer, status post-end ileostomy. She's short gut, has congestive heart failure, COPD, hypertension, hyperlipidemia, and insulin-dependent type 2 diabetes. I've included her height and weight. She's 157.5 centimeters and 52.3 kilos, which puts her at a BMI of around 21.1. She's been NPO for 5 days, and on her ICU day 1, she receives an exploratory laparotomy with lysis of adhesions, end ileostomy revision, and a complex abdominal wall closure. On day 2, she started on D10 at 10 milliliters an hour, and on day 5, we're consulted to start her on parenteral nutrition. For our next learning assessment, going along with our patient case, AG is now post-op and a consult has been placed for parenteral nutrition. Her labs prior to starting are potassium of 4.2, phos of 3.4, and mag of 2.2. Her serum creatinine is 1.08. According to the ASPEN consensus recommendations, what is this patient's level of risk for refeeding syndrome? So I'll give you a moment before I read out the options. So those for A, okay. B, moderate. Okay. C, severe. Or D, none of the above. Okay, so I see our online participants are a little bit more interactive than our in-person participants. That's okay. We'll get into it. But yes, so the answer is moderate. Okay. So kind of go through why it's moderate. First, looking at the NICE assessment in terms of how they would categorize this patient. So she was NPO for 5 days. She has that history of using insulin for her diabetes, as well as diuretics due to her history of congestive heart failure. So using the NICE assessment, this would categorize her high refeeding risk. However, with our ASPEN criteria, so she meets the no intake for that 5 days. And she has several of those high-risk comorbidities. So that history of cancer, she's short gut, she's post-op. So that's why she was considered to be at moderate risk. All right, moving on to our diagnosis of refeeding syndrome. So for ASPEN's diagnostic criteria, it's a decrease in any of the serum, phos, potassium, and or magnesium levels by either 10 to 20% as mild and 20 to 30% as moderate. If it's greater than 30% with or without organ dysfunction and or thiamine deficiency, this is considered as severe. And so refeeding can occur within that 5 days of reinitiating or increasing energy provision and last up to 14 days. All right, and so our next learning assessment, hopefully we'll have a little more participation this time. Which electrolyte is the primary marker for identifying refeeding syndrome? So those for A, sodium, B, potassium, C, phosphorus. Okay, now you can see what they're saying online. Y'all want to participate, right? Okay, that's okay. D, magnesium, E, other. Okay, yes, it was phosphorus. Alrighty, so that brings me to my second study of refeeding syndrome or refeeding hypophosphatemia. And this was a systematic review of cases published in ASPEN's Nutrition Clinical Practice Journal in 2012. So our results from this study, a total of 27 cases, were reported by 20 different authors. The patient population was ranging from 10 to 90 years old, and the majority of these patient cases were on Emory nutrition. The patients had a low BMI or impaired oral intake for greater than 48 hours prior to refeeding. And in this study, it showed that 26 out of 27 of those cases reported hypophosphatemia, with only 71% showing at least one electrolyte abnormality, with hypomagnesemia being a bit more common than hypokalemia. Only one of the cases showed thiamine deficiency, and 6 of the cases showed edema or weight gain. In summary, the low incidence of refeeding syndrome is likely a result of under-recognition and insufficient monitoring. However, hypophosphatemia is universally present and possibly used as the only marker for refeeding. So this review really raised questions of need for further defining refeeding syndrome compared to refeeding hypophosphatemia. Next, we'll go into our recommendations for prevention and treatment of refeeding in at-risk adults. Okay, another poll question. How do you initiate calories in a patient that is at risk of refeeding syndrome? So would you either A, titrate up calories over a period of time? Okay, I see you guys. B, meet patient's caloric needs. Or C, you're not sure. Okay, looks like we got 100% to say titrate up calories over a period of time. So the NICE guidelines recommend starting feeding at around 10 calories per kilo per day and slowly increasing over 4 to 7 days. And for our ASPEN recommendations, they recommend initiating with 100 to 150 grams of dextrose or 10 to 20 kcals per kilo for the first 24 hours. They keep in consideration if they are at moderate to high risk, then considering holding initiation or increase of calories until those electrolytes are supplemented and or normalized. And if they have severely low levels of PHOS-K or MAG, then initiation or increase of calories should be possibly delayed until those levels are corrected. In terms of calories from IV dextrose solutions and any other medications in dextrose, we want to initiate with caution in patients who are at risk. So, however, if a patient is receiving significant amounts of dextrose for several days and they are asymptomatic with stable electrolytes, then calories can possibly be reintroduced at a higher amount than recommended. So going back to our patient case, I've kept a little recap in terms of BMI. Day 2, we started that D10 at 10 milliliters an hour. If you calculate that, that's only 24 grams of dextrose. We said she is at moderate refeeding risk. And on day 5, we are consulted to start central parenteral nutrition. So with ASPEN, they would recommend, again, initiating with that 100 to 150 grams of dextrose. And if we calculate it out for calories in this patient, it would be around 523 to 1,046 calories. So for a patient case, we initiated calories at a rate of 42 mL per hour. There was 125 grams of dextrose in the bag, and we fed at her BEE of 1,208 calories, which was around 23 kcals per kilo. So now that we've discussed our calories, we'll go into our electrolytes. So the NICE guidelines recommend checking a serum potassium, mag, and phos before starting nutrition, and to rehydrate and or correct any levels of potassium with 2 to 4 MEq per kilo per day, phos of 0.3 to 0.6 millimoles per kilo per day, And for magnesium, if it's IV, then it'd be 0.4 MEQ per kilo per day and 0.8 for PO. With our ASPEN recommendations, they also recommend checking levels and then repleting those low electrolytes based on your standards of care. If it's difficult to correct or drop during your initiation of nutrition, then decreasing those calories and grams of dextrose by 50% and slowly advancing by around 33% of your goal every 1 to 2 days. So that brings me to my first electrolyte, phosphorus. Again, as a refresher, its mechanism for refeeding syndrome is due to the intake of carbohydrates, leading to increased phosphorus uptake, leading to hypophosphatemia. Phosphorus is a major intracellular anion and has a structural role in the component of phospholipids, nucleoproteins, and nucleic acids, as well as a central role in glycolysis and oxidative phosphorylation. Phosphorus is also required for energy storage in the form of adenosine triphosphate, or ATP. And a phosphorus level of 1.8 to 2.6 would be considered as mild hypophosphatemia, 0.9 to 1.8 as moderate, and less than 0.9 as severe. So going back to our patient case, prior to starting nutrition, she had a phosphorus level of 3.4. So how do we want to supplement from there? So keeping in mind, even with that normal phosphorus level and the start of that dextrose-containing fluids or our parenteral nutrition, that normal phosphorus level will most definitely drop. With dietary phosphate, it's predominantly absorbed in the jejunum with more than 90% excreted renally and 10% through gastrointestinal loss. So keeping that in mind when looking at patients' renal function. And when providing supplementation per protocol, keeping in mind if a patient's undergoing respiratory alkalosis, this typically increases phosphorus uptake by the muscle, leading to increased need, as well as in continuous renal replacement therapy, or CRT. And because I'm a pharmacist, I have to include some medications, right, that can decrease phosphorus. So Phoscarnet and our aminoglycosides, diuretics, corticosteroids, bisphosphonates, and of course our phos binders, such as aluminum hydroxide, calcium acetate, carbonate, and sevelamer. So going back to our patient case, how do we want to supplement this patient, starting off in our parenteral nutrition? So keeping in mind that our daily requirement of phos is around 20 to 40 millimoles per day. And so we did supplement around that range with 25 millimoles in the bag. And you can see the next day it dropped to a level of 1.5. So this was around a 56% decrease in phos. And so thinking about our diagnostic criteria, this would be considered as severe refeeding syndrome. And because of that, again, keeping in mind that we will want to decrease our dextrose by 50% and slowly titrate up. And because it is severe refeeding syndrome, keeping in mind to add thiamine into your parenteral nutrition upfront. And I'll discuss this a little bit more later on. So of course, we increased the total phos in the TPN to 35 millimoles, and she receives outside supplementation of K-phos. With K-phos, keeping in mind to infuse it over 6 hours, since it does have a max infusion rate of 7 millimoles per hour. So on day 2, the phosphorus level increases to 2.1, still low, so we increased the total amount in the TPN. And from days 3 to 5, you can see that the phosphorus level starts to normalize out, and we're able to slow back down in the TPN, signifying that the worst of the evening is over. Our next electrolyte is potassium. Again, very similar mechanism. That increase in carb intake and insulin secretion leads to increased uptake of potassium, leading to hypokalemia. Potassium is predominantly the monovalent intracellular cation and can be depleted in undernutrition. It's also essential for maintaining cell membrane action potential, and a level less than 3 would be considered as severe hypokalemia. Again, going back to our patient case, so she started with a potassium level of 4.2, and again, that was with the start of the D10. So how much do we want to supplement? So things to keep in mind, majority of potassium absorption occurs in our small intestine, with the total body potassium being regulated by the kidney. The distal nephrons secrete potassium into the urine. So again, keeping in mind with our renal patients. Providing appropriate supplementation, again, per protocol. And medications that can decrease potassium include albuterol, amphotericin B, Phosphorus, our diuretics, of course, being the most common, insulin, and laxatives, just to name a few. So going back to our patient case, how should we supplement potassium? So daily requirement is around 1 to 2 MEQ per kilo per day. So in our patient, that would put her around 52 to 105 MEQ per day. So again, we supplement within that range with 70 MEQ in the parenteral nutrition. And the next day, the level still drops to 3.7. So this was around a 12% decrease in potassium. So if we were looking at potassium specifically with the ASPEN Diagnostic, this would be considered as mild refeeding. So on the next day, we increase the amount of potassium in the TPN to 80 MEQ, and she receives outside supplementation. And again, from days 3 to 5, you can see that potassium level start to normalize slowly back down in the TPN. Our next electrolyte is magnesium, and its mechanism for refeeding is multifactorial. Again, due to the intracellular movement into the cells with carb feeding, as well as poor dietary intake and pre-existing poor magnesium status, this will all precipitate hypomagnesemia. Magnesium is the most abundant intracellular divalent cation and is mandatory for optimal cell function. It's an essential metal involved as a cofactor to many enzymes, and it's necessary for the structural integrity of DNA, RNA, and ribosomes. A magnesium level less than 1.2 would be considered as severe hypomagnesemia. Again, as a recap, going back to our patient case, so she had a magnesium level of 2.2 to start off with. So things to keep in mind, magnesium is largely absorbed in the upper small intestine, with 70% of dietary magnesium intake not absorbed but eliminated in the feces. The major excretory route is through the kidneys as well. And when providing supplementation, keeping in mind that with oral magnesium oxide, an adverse reaction is diarrhea. And so in our patients who are having diarrhea or have absorption issues, considering the use of IV magnesium sulfate. And in terms of medications that can decrease magnesium, this includes our calcineurin inhibitors, such as cyclosporin and tacrolimus, amphotericin B and Phosphorus, diuretics, PPIs, and insulin. So for our patient case, again, that magnesium level started off as 2.2. Our daily requirement is around 8 to 20 MEQ per day. And so we did supplement a little outside of that daily requirement with 24 MEQ total in the TPN. And again, the next day, the level drops to 1.9. And so this is around a 13% decrease in magnesium. So again, this would be considered mild with ASPEN's diagnostic criteria. And so we keep the same amount of magnesium, but again, around days 3 to 5, you can see that we slowly back down in the TPN, again, signifying that refeeding is over. So our next learning assessment, which medication has the potential to lower potassium, phosphorus, and magnesium? They beat us, okay. A, carnitine, B, omeprazole, C, Phosphorus, or D, spironolactone. Yes, so the answer was C, Phosphorus. That brings me to my last electrolyte, which I've kind of grouped up with fluids. The introduction of carbs to a diet leads to a rapid decrease in renal excretion of sodium and water. And so with fluid repletion to maintain a normal urine output, this leads to fluid overload. This can lead to congestive cardiac failure, pulmonary edema, as well as cardiac arrhythmias. So our NICE guidelines do have recommendations in terms of how to initiate our fluids. So they recommend 30 to 35 milliliters of fluid per kilo. Of course, keeping in mind any extra losses from drains, fistula, and or any extra input from other sources as well. Our ASPEN recommendations did not have any recommendations for fluid or sodium intake. And going along with that, another manifestation that can be seen with refeeding is refeeding edema. This is a late manifestation that occurs mainly in patients with anorexia nervosa. This is due to their heightened insulin sensitivity. Since insulin promotes sodium reabsorption, this can lead to fluid retention, weight gain, and localized and rarely generalized edema. This will typically resolve spontaneously, so it's important to monitor our daily physical exams, vital signs, weight, fluid balance, and of course our electrolytes. So we'll now discuss our vitamin supplementation. So the NICE guidelines recommend providing thiamine before feeding of 200 to 300 milligrams PO every day, and to supplement a multivitamin or trace element every day as well. ASPEN recommends also supplementing our thiamine, of course, with 100 milligrams PO or IV every day before feeding, or before starting any dextrose-containing IV fluids in our at-risk patients. This can be extended to up to 5 to 7 days or more in our high-risk groups. And multivitamins should be added to our parenteral nutrition every day unless it's contraindicated. For our PO or enroll patients, adding a multivitamin every day for at least 10 or more days. So with thiamine deficiency, again, with carbohydrate refeeding, this leads to increased cellular thiamine utilization. Our normal reference range is around 70 to 180. And some risk factors that for thiamine deficiency also include chronic alcoholism, malabsorption, malnutrition, gastric bypass, increased carb intake, of course, and congestive heart failure patients receiving furosemide. So kind of keeping in mind to look for these patients, since it can be compounded with refeeding syndrome to lead to lower thiamine levels. So with low thiamine levels, what kind of symptoms can we see? So I've kind of separated them based on the different types of beriberi, with the first being dry beriberi. So this includes nervous system involvement, weakness in the legs and arms, muscle pain and tenderness. In wet or cardiac beriberi, you can see rapid heart rate, severe swelling or edema, difficulty breathing, as well as congestive heart failure. And in cerebral beriberi, Wernicke's encephalopathy and Korsakoff syndrome. And in gastrointestinal beriberi, lactic acidosis, nausea, vomiting, and severe abdominal pain. I've starred congestive heart failure and Wernicke's encephalopathy as these are the most common. So this is our last full question. You have received a consult to start parenteral nutrition and your patient is at moderate risk of refeeding syndrome. What dose of thiamine would you start? And I'm not going to put the poll up yet to give you all a minute. So for A, 100 milligrams IV or PO. Okay, see a few people. B, 150 milligrams IV or PO. Oh, now y'all don't want to answer. C, 200. Okay, got some for 200. D, 500. Would anyone do 500? Or E, none of the above. Okay. It is. That's why I made it a poll question rather than a learning assessment. So yeah, there can be a range, of course. There's no right answer. Yeah, so I discussed what the NICE and ASPEN guidelines would recommend. So around that 100 to 200 milligrams every day, pure IV for 3 to 5 days. Of course, this can be increased up to 500 if you see, encephalopathy. That's the typical dose that would be seen. And if you are supplementing with thiamine, keeping in mind that the oral absorption is 4, so only around 4.5%. So in our at-risk patients, really considering the IV option rather than PO. In terms of ordering the lab, it is a thiamine full blood level because the biologically active form pyrophosphate, or TPP, accounts for 90% of thiamine content in the whole blood, in comparison to the plasma thiamine concentration, which only reflects recent intake rather than whole body stores. So because of this, it's usually a sent out lab. It can take many days to receive. So rather than waiting around for that lab, go ahead and treat upfront if there's any suspicion of refeeding syndrome. And it's typically like that classic lawsuit if you don't add it up front. So always add your thiamine. And for our last manifestation that can be seen with refeeding is refeeding diarrhea. This can occur during the early stages of refeeding due to the atrophy of the intestinal mucosa and pancreatic impairment. So this typically resolves within the first few weeks of refeeding as the villus surface is reconstituted. And so some ways to ameliorate this, of course, through our antidiarrheal, fiber or bulking agents, as well as slowly advancing to feed if they're on intervals. So to wrap things up with monitoring and long-term care, the NICE guidelines recommend monitoring, again, our potassium, phos, and mag for 2 weeks and then amending treatment. And ASPEN recommends, again, monitoring those same electrolytes every 12 hours for the first 3 days in high-risk patients. They also recommend vital signs every 4 hours for the first 24 hours after initiation of calories, as well as cardiorespiratory monitoring if they are unstable. Daily weights with monitored ins and outs are also recommended. And for our long-term care, really evaluating those short and long-term goals for nutrition during the first several days until the patient is stabilized. So in summary, to bring everything together, remembering to identify those patients at risk. So looking out for elderly patients with anorexia, chronic illness, poor nutrition, cancer, and then taking those steps to prevent refeeding from occurring. So supplying any low electrolytes, go ahead and supplement that thiamine upfront, even if you have a lab that's in normal range. And to start refeeding and hydration cautiously. Next step would be to look out for any characteristic signs and symptoms after starting refeeding. So looking at our electrolytes, again, our phos, potassium, magnesium, and to be alert if there are any symptoms of tachycardia, tachypnea, edema, confusion, or any ECG alterations. Then treating any electrolyte imbalances and managing refeeding, keeping in mind that those first 5 days are the most crucial. And for monitoring, looking at our body weight, vital signs, clinical exams, and lab parameters. And with that, that is the end of my presentation. I'll be glad to take any questions. Thank you, guys. Yes. I usually don't. But yeah, it is higher, and I feel like since it is older from 2006, I feel like our practice has definitely changed till now. So yeah. Yeah. And that they were not used reference. There was like such a low incidence of those codes that I'm guessing it's probably not that data. There's 9% in pharmacy. Like, do you get reimbursement for them? So the question was, how can we better diagnose refeeding syndrome, and if we can get reimbursement? And for that part, I'm not too sure about the reimbursement part, but in terms of the diagnosis, looking at those low electrolyte levels, specifically, I would say phosphorus is the one I use the most in my practice. Of course, making sure you have labs ordered. And for me personally, I always supplement typically above that daily requirement up front, because I know my phosphorus level is going to drop a lot. So that's kind of my best way to kind of upfront preempt refeeding syndrome, just supplementing electrolytes, depending on how much you're feeding as well, of course, if you're titrating versus feeding full calories. Yeah. And with the incidence, unfortunately, there is an agreed upon definition whether all of these electrolytes that are being depleted or just phosphorus alone. Of course, we kind of do more studies, I feel like, to kind of see if it's just phosphorus alone versus all of these electrolytes together. Yeah. Oh, the question. The question was, what to differentiate between refeeding syndrome versus refeeding?
Medication on parental nutrition then transition to Emory nutrition. I'm getting that refeeding diarrhea or something like that.
So the question was, after starting someone on parenteral and then switching to enteral, if we still see refeeding occur. And I would say I have not seen it. I don't know about anyone else, but I have not seen it, as we typically do feed up front in our parenteral nutrition, and kind of after that first 3 days, the refeeding kind of subsides. And so once you're going to enteral nutrition, you know, that rate is being titrated up and down, on and off. So it's not as commonly seen for me in my practice. Yeah. So ASPEN was found as oral absorption around 4.5%, and whether or not it's absorbed in the phosphorus in the GI tract. So I didn't know that specifically which part of the GI tract for absorption. It's kind of just overall. Okay. Yeah. Yeah. Question for everyone online. So the question was, with our shortages of beds, clinicians, all of that, whether or not I would essentially feed in upfront and titrate calories a little bit more quickly. So in my practice, I actually do feed calories upfront. The full nutritional need, I kind of don't really titrate up. And with knowing that, I absolutely supplement above that daily requirement for all my electrolytes, always keeping in mind renal function if they're on hemodialysis or CRT, putting in that thiamine, and always taking into consideration all of my at-risk populations. And that is actually what my research project was on. And I noticed that refeeding did subside in that 3 days. And none of the the phosphorus levels were considered severe, and so it is, you know, practical to practice this way. And we have noticed it helps with getting our patients out a little bit more quicker, freeing up those beds, like Brian mentioned. And again, keeping in mind that these are recommendations, of course, and so as long as you're practicing, you know, safely, yeah. Yes.
Patients who are receiving nutrition support, but do eat like a lot of expensive liver guidelines. Are we concerned patients on oral diet?
So the question was if we're as concerned for patients started on an oral diet. Essentially, so I would say if a patient is severely malnourished, if they are put on just a PO diet, they're likely not going to be taking enough to really experience refeeding. However, if they are on a PO diet, they're started on any medications that are in D5 at a high rate or any fluids. That's where I really caution, you know, our doctors and everyone else to supplement those electrolytes up front. If you know, a dietitian or nutrition support clinician isn't following the patient, because refeeding can most definitely occur with those doctors. Okay. Yeah. Yes, I would recommend supplementing with oral thiamine if they're just on a PO diet. Again, keeping in mind that refeeding may not be as severe to, you know, kind of the IV thiamine form. But yes, 100 milligrams every 3 days, always. All right. Thank you so much.
A little early, so maybe supposed to start lunch early, right? So I just want to let you guys know we're going to have a 75-minute lunch break, and just make sure if you haven't collected all your signature that you haven't. So enjoy your food and go see our sponsors, okay? And then make sure to drop off your completed ticket in one of the basket outside, and then we'll do the drawing afterward. And for our virtual attendees, enjoy your lunch, and I know you're gonna miss out our great food that we have here, right? But you are welcome to actually, for virtual attendee, they can watch the sponsor presentation and also poster presentation online as well. And I know for the in-person, you might not have the chance to view any of the poster presentation, but it will remain on our website, and you can actually take a look at them whenever you have the chance. All right, so we will resume at 1:15, okay? I mean, you first.